All right, so let's talk about ECG for a minute. Now, regarding the topic of ECG, I'm not going to go into details about every single part of an ECG. In today's video, we're going to just revise quickly the basics of an ECG, and we're going to apply our understanding or our basic understanding of ECG on two infamous conditions, more commonly MI, myocardial infarction, as well as some cases such as left ventricular hypertrophy. But we're not going to be talking about in details such as left bundle branch block or the different types or the different grades of an AV block. In today's video, we're just going to learn the basics of an ECG and how we can apply it or interpret it on an ECG paper, especially in a case of MI. So it's going to be a short video. So let's talk about ECG for a minute. Now, as you know, ECG, this is a beautiful investigation. This gives you the message or the electrical message of the heart. As you know, the heart, like this one right here, the heart is an electrical pump. In order to do its function, which is acting as a blood pump for itself and for all the other organs in the body, it needs power. And that power is electricity, or more specifically, action potential. And it generates this action potential in an organized manner throughout all parts of the heart, because as you know, the heart is subdivided into right and left side, and each side of the heart has an atrium, a ventricle, a septum in between, and a valve in between atrium and ventricle from the same wall, right? And as you know, it receives its blood from the blood vessels, whether it's in the form of veins or in the form of arteries, okay? Of course, the function of the heart is to receive its deoxygenated blood from the superior vena cava or the inferior vena cava from the atrium. Then the atrium contracts, pushes it to the right ventricle, then the right ventricle contracts, pushes it towards the pulmonary trunk, where it will be oxygenated, this blood, and then this blood will return back to the heart through the pulmonary veins, back to the left atrium. The left atrium will then pump to the left ventricle, and then the left ventricle, which is the most important part really for the heart, the strongest part, it will pump with a very strong amount of force towards the aorta, specifically the ascending aorta, then to the aortic trunk, and then towards the descending aorta, to all kinds of blood vessels to supply the heart. Now, how can the heart basically be able to pump blood, whether deoxygenated or oxygenated blood, in a systemic manner? How is it able to do that? Well, through its electrical system. And this electrical system of the heart is organized as the following. You're going to have the following of an SA node, as you know, sinoatrial node. Look at it in the right atrium. The SA node will send action potential always with each beat of the heart. And it will send an action potential, and it will send it towards the AV node. But before it sends an action potential to the AV node, it's going to send an action potential to contract for the right atrium and the left atrium. Then it will send what is known as a delayed action potential. You see, you don't want the heart to have its atrium and its ventricle contracting at the same time. No, the pumping has to be properly done and has to be done in a systemic and efficient manner. So the SA node will send action potential in a delayed fashion, in a delayed manner to the AV node. From the AV node, it will go ahead and send its electric potential to the ventricles. It will contract, and then it will go to the bundle of hairs, and from the bundle of hairs, it will go to the Purkinje fibers. The idea here is that the majority of the action potential is going to go inferior lateral side of the heart. The majority of the electricity is going to go inferior and lateral part of the heart, mostly. It will go everywhere. It will go to the atriums, it will go to the right ventricle, but most of it will be directed towards the inferior lateral portion of the heart. The idea here is that we're going to send an action potential or an electricity to every part of the heart, but one by one. First the atrium has to contract, then the ventricle can contract, so that we're able to pump blood efficiently, right? And if there's any problem in this electrical system, in the SA node, or the AV node, or in the Purkinje or bundle of hairs, if there's any problem with it, then it will lead to a bunch of problems. One just simple example where there might be an abnormality here in this electrical system, There's one abnormality known as Wolff-Parkinson-White syndrome, where you have another road to basically have this electrical potential go to the AV node again. So it will go circle and circle and circle and circle, right? And it will have a very massive ventricular tachycardia. So we just want to explain the electrical system of the heart for a minute, right? It's through this electrical system, the AC node, the AV node, the bundle of hairs, and the Purkinje fibers. Why is this important? Because we will record this activity right here. We want to record the electrical activity of the heart through papers, through graphs. And what do we call this? ECG, electrocardiogram, all right? So the ECG is where we're able to see the electrical activity of the heart and interpret it. Is it normal or is it abnormal? Which will help us in diagnosis. Now, in order to record the electrical activity of the heart, we need a camera, and this camera are what is known as leads. Now leads, or you might have heard of the term electrodes before, leads you can think of them as cameras, where they will record this action potential, which is mainly going inferior lateral portion of the heart, right? So I'm gonna have a camera that will record the heart inferiorly, anteriorly, laterally, and so forth. So I'm gonna record the portions of the heart from each side. Inferiorly, anteriorly, and laterally, mainly, all right? And from this recording of this action potential that's mainly going anterior laterally, or inferior laterally, sorry, from this recording from a specific direction, it will give me a specific reading. This reading might appear different, or mostly it will appear the same as the other leads, okay? So in order to record the electrical activity of the heart, I need a camera. This camera are your leads. And of course, in order to record the electrical activity of the heart, these leads will act as cameras. They will have an action potential that will go towards them. They will have an electrode. They have a positive electrode and a negative electrode. The action potential that is basically being recorded in front of this lead, in front of this electrode, is known as a positive electrode. So it will record it in a positive manner. But if we have an action potential that is moving away from the lead, away from the electrode, is known as a negative electrode. It will still record the electrical activity of the heart from a specific direction, but the electrical activity of the heart, it will not appear as positive. It will appear the opposite, inverted, like this picture right here. It's going to appear negative because the electrical activity of the heart will be away from the lead. And that's what every lead is. It's composed of electrodes, positive and negative electrode. It will record any electrical activity that is coming towards it as a positive deflection. Any electrical activity that is away from it, that is a negative electrode, it will basically interpret it as a negative deflection, okay? So this is what every lead is. And how many leads do we have that we will actually attach on an individual? How many leads? We have 12 in total. We have what is known as limb leads, and then we have what we have known as precordial leads. Now the precordial leads are a bunch of leads we will attach on a patient. Here, 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 here. We have 6 total. So they all start with V1. So we have V1, V2, V3, V4, all the way to V6. These are your precordial leads attached at this, basically around the center of the heart, from interior all the way to the interior axillary line. And they will record the interior portion of the heart. In general, they will record the interior portion of the heart, specifically V1 to V4. And V5 and V6 mainly record the lateral portion of the heart, all right? So these leads, they will take action potential coming towards them, and they will give us the reading that looks like this, all right? So these are your precordial leads in the center. But we have also what is known as limb leads, the remaining leads. They are attached on your limbs rather than your chest. So we have leads that are like lead 1, lead 2, and lead 3. Now lead 1, we will basically have it attached where? On the left side of the heart, on the left side of the arm, all right? We can have it on this side right here, on the left arm. Let's say on the left arm for simplicity's sake, all right? Or let's say on the shoulder. Regardless, it's going to be on the left side of the body. Now this is lead 1. We're going to have it attached here. Lead 2 and lead 3, we're going to have attached it on the left portion of the leg. The right leg is never used to insert a lead here. Typically, they will insert it as like a reference point, a zero reference point, something that will not record any electricity. It's just there while we place the other positive electrode in another direction, so it will take action potential. So the main idea, the right leg will not be used. It is the left leg, and the left leg is used by a total of 3 leads. I already said that lead 1 is going to be used mainly on the left side of the body. Well, lead 2 and lead 3, the remaining brothers, they're going to be on the left leg, all right? And where will they be taking electrical activity of the heart? Where will they record it and send us a picture? From the inferior portion of the heart. So lead 2, lead 3, they will take a picture from the inferior portion of the heart. And same goes for the next remaining leads, AVF. AVF from the feet. So now you have a total of 3 leads that will record from the inferior portion of the heart its electrical activity. Lead 2, lead 3, and AVF. Regarding the left side of the heart, we have lead 1. Lead 1 will actually record the lateral portion of the heart. Let's add another lead, AVL. Lateral. It will also record the lateral portion of the heart. And now let's add also with it V5 and V6, which also record from the lateral portion of the heart. So now let's revise just one more time. How many leads do we have? We have 12. Lead 1, lead 2, lead 3. Besides that, we have also V1, V2, V3, V4, V5, V6, your precordial leads. And then the remaining ones are your AVF, your AVL, and now your AVR, which is the only one that records from the right side of the arm. It will record the heart from the right portion, all right? Now, as we said before, the heart, most of its electrical activity will go in the direction of inferior lateral, right? So the AVR, it will receive action potential, but this action potential will be moving away from it. So it will give us an electrical reading that will be inverted. Why? Because its action potential is moving away from the AVR. This is the AVR. The heart is contracting or sending electrical activity from this area, the opposite direction. So it will record the electrical activity as inverted. Okay? So that's the only lead, by the way, that is inverted. So we have AVR. Again, let's summarize. 12 leads. Lead 1, lead 2, lead 3. Then you have V1 to V6, your precordial leads. Then you have AVR, AVL, AVF. All the leads that are in your limbs, they are known as limb leads. All the leads that are seen in your chest, they are your precordial leads. Every lead will record a specific view of the heart. Some leads share the same view, like lead 2, lead 3, and AVF. They'll record from the inferior portion of the heart. Some leads will record from the lateral portion of the heart. Your lead 1, your AVL, your V5, and your V6. And what about recording the portion of the heart from the opposite direction? Your AVR. All right? These are your leads. Now that we've got that out of the way, now let's see the image that they generate. Now let's see the picture that they took and send it to us on an ECG graph. This is what it looks like right here. It can be positive deflected, meaning the electrical potential comes towards it, positive electrode, or it could be inverted, all right? That can be normal, and only in the case of AVR. But all the remaining leads will give this picture, but in AVR, it will give you this direction. So it could be positive deflection, negative deflection. Negative deflection is always abnormal. In ECG, if there's any negative deflection and inverted, it's always abnormal, unless it's a case of AVR. The abnormal is normal for them. Why? The action potential is going away from the AVR, okay? All right, now that we've got that out of the way, now let's talk about the image that's generated from an ECG, all right, by our beautiful leads, all right? Now, one more thing, before I talk about what each of these mean, there's a basic understanding, I also want to mention as well what is known as the cardiac axis. Now, what I want you to just imagine, this dot represents the heart, right? And remember, the most of the electrical activity goes where mostly in the heart? Inferior lateral, right? Towards the left ventricle. So we create a cardiac axis where, okay, if the majority of the electrical activity is going towards inferior lateral portion, then this is normal. But let's say we have the majority of the electrical activity not going towards it. Let's say it's going right. It's deviated towards the right axis. It's deviated above. It's deviated somewhere else. Well, that's where you have a case of a cardiac axis. Basically, a cardiac axis is like a clock. The dot here represents my heart. And each of these are your degrees. Basically, these degrees, you can think of it as where each lead will be recording from exactly. For example, 0 degrees, that is your lead 1. All right? This is your lead 1. Lead 1 here, for example. Let's say in 90 degrees here, we have AVF. It will record from the inferior portion of the heart at 90 degrees. Next to AVF at 60 degrees, you have lead 2. 120 degrees, you have lead 3. Okay? And then you move on, like 180 degrees, that can be AVR, right? And then from that point on, you go look at, for example, all the remaining leads. Where is AVL and whatnot? AVL can be at minus 30 degrees. Regardless, what I want you to remember from this cardiac axis is that this dot represents the heart. And as you know, the heart, the electrical activity will be recorded from all directions, from all the leads at a specific degree. 0 degrees, lead 1. AVF, 90 degrees positive number. For example, AVR could be 180 degrees. So they will be recording it from specific degrees, okay? Why is this important? Because this will tell me whether the majority of the electrical activity is going inferior lateral or not. So the normal range here specifically for the axis deviation or for the cardiac axis, the normal range is at between minus 30 to 90 degrees. This is your normal reference, okay? From negative 30 to positive 90 degrees, this is your positive normal range, all right? This means normal axis deviation. This means the heart, it is pumping towards this direction. Let's say this axis is deviated. Let's say a patient has right axis deviation, for example, all right? Then what will it look like? Do I diagnose this case as right axis deviation from the cardiac axis? No, I will diagnose it from the ECG, all right? So I just want you to understand, cardiac axis is important to know whether it's normal or abnormal. If it's abnormal, then it will appear as, for example, left axis deviation or extreme left axis deviation, or it will appear as right axis deviation, okay? There's a deviation. It's supposed to be between minus 30 to 90, but the axis can be up outside of this range. It could be beyond it, all right? So let's look at an example. For example, if I have a case of an ECG reading, and I want you to focus on this, this is the R wave. If I see, for example, this is lead 1, all right? Like we said, lead 1 is 0 degrees, right? And the one that's at 90 degrees, this is AVF. So in an ECG reading, clinically, I will look at the peak of the R wave, all right? Just focus on this, focus on the R wave. I will look at the peak of the R wave. I will see, is it positive deflected like this, or is it negatively deflected, all right? See, normally, both of them are deflected. And what I mean by that, I mean that when you look at an ECG for lead 1 and AVF, both of them should be positive, all right? This is the normal. This is lead 1 and this is AVF. Both of them should have a positive direction. Use your thumb. But let's say in lead 1, I saw the R wave, it was positively deflected, but in EVF, it was negatively deflected, all right? Negatively deflected. Like this. This is left axis deviation, all right? This indicates abnormality, left axis deviation. And this is not specific to anything. This can be due to left ventricular hypertrophy, left bundle branch block, inferior MI, has a whole bunch of cases. So that's why if you have a left axis deviation, there's abnormality. You have to find other findings to confirm what is the exact cause of left axis deviation. So I have a sum here, sums up and sums down. The sums up, I check at lead 1. Lead 1, positive deflection, mumtaz. AVF, positive deflection, normal. Top negative deflection, sums down. This is left axis deviation, LAD. So let's say the opposite. Let's say in lead 1, I see a negative deflection, okay? But in AVF, I see a positive deflection. So they are kissing each other. Then this is right axis deviation, all right? Right axis deviation. This again has a bunch of numerous causes that you'll have to look at other findings to determine what exact. So the idea here is we want to look at one of the possible abnormalities we might see on an ECG. One of the possible abnormalities we might see on ECG is axis deviation. Is it right or is it left axis deviation? Okay? When I want to look for axis deviation, I just look at two LEDs. LED 1 and AVF. I compare the two. I look at the R wave, positive and negative deflected. Use your sums. Okay? Now, I just wanted to get that out of the way so that now we can talk about the other abnormalities we want to know in an ECG to differentiate from the normal. Now, let's look at an image that is generated by our LEDs on an ECG graph. Okay? This is the image right here. This P wave, this is your positive deflection, this small one. This is your P wave. This means atrial depolarization. All right? Then you have a slight pause. You have a slight peace time period. You have a period where there's nothing going on after atrial depolarization. This is known as your PR segment. But if you want to add it together from the beginning of the P wave to the beginning of basically the Q, this is known as your PR interval. So again, from the beginning, the first image goes step by step. This is your P wave. Your P wave represents your atrial depolarization. Afterwards, there's going to be a period of peace, nothing going on. Then there will be ventricular depolarization, and it will be in the form of QRS. QRS. All right, this QRS represents your ventricular depolarization. And why is it going down, up and down? In summary, it is because the anions or the cations, let's say the cations, the direction they're going, like we said, the action potential, they might go towards the electrode, they might go away from it. So some of it may appear as negative deflection, some of it may appear as positive deflection. It is according to the direction of the action potential for that specific LED. That's why some of it may go down and up. But regardless, QRS represents your ventricular depolarization. And if we look at the beginning of a P wave all the way to the beginning of a ventricular depolarization or the beginning of a Q wave, this beginning from a P wave to a Q wave is your PR interval. This represents the time between atrial contraction all the way to the beginning of ventricular contraction, all right? And in the case of PR interval, it is important that it is not prolonged, all right? It should be between 0.12 to 0.20 seconds, all right? That is the normal range, from 0.12 to 0.20 seconds for the PR interval. It shouldn't be prolonged. You can see it in cases of heart block. You can see it in cases of ischemic changes, especially in MI. We'll get that shortly, okay? So we finished that out of the way. P wave, this is your atrial depolarization, then PR interval between the P wave to the beginning of Q, which is ventricular depolarization, QRS, all right? Then there will be a period of time of peace. Again, nothing going on. So we have, after the ventricular depolarization, there will be nothing going on, then there will be another depolarization, or a positive deflection, not depolarization. This wave right here is known as your T wave. T wave here represents your repolarization, all right? It represents repolarization of the heart overall. So this time period of peace between the S and the T, they give it a name. They call it ST segment. Now, ST segment means a period of time between ventricular or between the end of ventricular depolarization to the beginning of ventricular repolarization. And this ST segment is very, very important. Why? Because it should be flat, all right? It will not increase, it will not be prolonged, all right? It just should be flat, all right? If, for example, this ST segment was elevated, abnormal. If it's depressed, abnormal. The ST segment should always be flat at the isoelectric line, meaning the line basically this line right here. This is your isoelectric line in ECG, where it should be flat. It should always be flat in this line. It shouldn't go up, meaning positive deflection above the line, or negative deflection, depression below the isoelectric line. The ST segment should always be flat. And I'm stressing on ST segment because this is a classical feature in MI, where it could be elevated or depressing, all right? So this is a sign of MI or ischemic changes. But again, is ST segment specific to MI? If I see ST segment elevation, does this mean 100% this could be MI? No, not necessarily. To diagnose it in a case of MI, you have to see, for example, ST elevation in more than one lead. If I see it in V1 and V2, then this is MI. This is ST segment elevated MI in a case of anterior MI. I have to see it in more than one lead consecutively, V1 and V2. Or I have to see it in the leads that record from the same view of the heart. If I see ST segment elevation in lead 2 and lead 3, this is likely STEMI or ST segment elevated MI, specifically inferior MI, okay? Because here's the thing, if you see ST segment elevated in one lead, this can be a whole bunch of causes. This could be hyperkalemia. For example, it could be associated with a whole bunch of things, all right? So it's not specific to it. You have to have ST segment elevated with more than one lead affected. If you want to be more specific, this ST segment elevation should cross a box. If you look at any ECG, it's going to be composed of large boxes, and these large boxes are composed of small little boxes. So it should have an elevation of more than 2 millimeter, all right? This ST segment should be more than 2 millimeter. It should cross one small box or above it, all right? So this is to specifically diagnose MI. You want the ST segment elevated to be 2 millimeter elevation, and it should affect more than one lead. If you see in just one lead, this can mean a whole bunch of things, like hyperkalemia, all right? So that's something to keep in mind as well about the ST segment. It should normally be flat, neither depressed or elevated. So let's summarize the image reading. The image reading of an ECG. You will have a P wave, atrial depolarization, then PR interval, you go to the Q, then QRS, ventricular depolarization, then S wave, the ST segment flat till you reach the T wave. The T wave is your ventricular repolarization. And then it will give the same recording again, the same recording over and over again, all right? Every lead will give you the same picture. In case of AVR, it will be inverted, okay? It will be inverted. This is the normal, all right? This is literally the normal. The ST segment should be flat. The PR interval should be between 0.12 to 0.20 seconds. It shouldn't be prolonged. It will not be elevated. It just shouldn't be prolonged, all right? The P wave should be present. The QRS obviously should be present. And it shouldn't be neither narrow or wide, and we'll get to that shortly. And the T wave should also be present as well. In some cases, as another abnormality, we're already seeing examples, like a prolonged PR interval. That's the one abnormality. We've seen ST segment. Another abnormality, inverted T wave. If you have an inverted T wave, that's not an AVR, that's a sign of ischemia, all right? That's literally a sign of ischemia. This is abnormal in all the other legs. So if you see inverted T wave, prolonged PR interval, ST elevation or depression, and let's say we also have the QRS inverted as well. Let's say we have a deep Q wave that basically looks like this, all right? It literally looks like this. Here's a P wave, then boom. This is literally the deep Q wave. If you have it inverted like this is another one that basically indicates ischemia as well. I am summarizing to you 4 cases as of now. Prolonged PR interval, ST segment, elevation or depression, inverted T wave, and deep Q wave. All of these are signs of ischemia, especially in cases of MI. So these are abnormalities you might have to find on an ECG. You join all of these together, and then from that point on, you can search for left axis deviation or or right axis deviation, all right? And then from that point on, with your ECG learning and other videos, you find out whether this patient has a narrow QRS or prolonged QRS or a T wave that is just as high as the R wave, the same peak essentially. Again, this all comes with further understanding. But for now, remember these 4 abnormal findings with right or left axis deviation, okay? Now we finished that out of the way. Now, one more thing as well. You see, on an ECG paper, one thing to keep in mind, this reading will be in the form of boxes, right? Any ECG paper will have these boxes, right? In this box, horizontally speaking, all right? Horizontally speaking, they represent the time, all right? Every box represents 0.20 seconds, all right? Every big box composed of small boxes. So every big box in an ECG horizontally represents time. And each big box represents 0.20 second. And every big box is composed of small boxes, right? And every small box is equal to 0.04 seconds. You add these together, they become equal to 0.20 second. So what I want you to keep in mind on an ECG paper, they'll have these big boxes. When you look at them horizontally, they represent the time for this recording, right? That's why we get the reading of PR interval. The normal was between 0.12 to 0.20. That means the number of boxes should not be more than 3, for example, all right? So that's what I want you to keep in mind for these boxes as well, whenever you're reading them. And what about when you read them vertically? What does this mean when I want to look at it vertically? You'll see in ECG, vertically, they'll have what is known as a millivolt. What does that mean? It means the magnitude. So, for example, the one with the highest magnitude, the one with the most electrical potential coming towards a lead will be the R wave, for example. So vertically, when you look at an ECG vertically with these boxes, they represent magnitude, voltage, high voltage. When you look at it horizontally, you're looking at time. The time for this image to be recorded throughout for the heart from a specific view, all right? So that's something to keep in mind. And how can we apply this knowledge? Well, how can we apply this knowledge? Well, there's one condition. That's not the only finding, but in one condition such as left ventricular hypertrophy, you can have basically, especially let's see in V6 or V5, you can have an R wave that is very high. So let's say we have a P, Q, R, S, and then you have the T, all right? Let's say, let me move that. Let's say we have a V5 lead that shows P, Q, R, S, T wave. You see, what's the abnormal here? Or what is the abnormal here, sorry? The abnormal here is that the R wave is high. Its voltage is high. Really, in general, the QRS voltage, it is high. Its magnitude is very high. This is a sign of left ventricular hypertrophy, which is characterized by a high QRS voltage, up to 35 millimeter, all right? They cover up to 35 millimeter, more than one small box, definitely, all right? So that is a sign of left ventricular hypertrophy. So you want to read an ECG, read it horizontally, but you can look at it vertically. When you look at it horizontally, you're looking at the time, right? You're looking if there's things that are present, P, Q, R, S, T. You're seeing if they're present. You want to see the time. You want to see the regularity and all that. But when you look at it vertically, you're looking at the magnitude. They're abnormal magnitudes. Some people may have a T wave that is just as high as an R wave, a double. Some may have a QRS voltage that is very high, and that's especially seen in cases of left ventricular hypertrophy. That is one example of it, all right? So now that we've got that out of the way now you know how to how to identify ECG from a basic understanding of it, essentially, all right? And like we said, always on an ECG, like as always in an ECG, read it normally. Every ECG will have lead 1, lead 2, lead 3, AVF, all right, AVR, let's say, AVF, AVL, and then you have all the V's, right? It will be organized in this manner, right? You look at every ECG lead, all right? you look at it in this manner and you'll see whether P, Q, R, S, T are there. If they're there, you look for the abnormality. Is there a prolonged PR interval? Is the ST segment above or depressed? Is there a left axis, right axis deviation? For example, is there a high QRS voltage? Is there an inverted T wave or a T wave that is just as high as an R wave? Its magnitude, yani. Is there a deep Q wave? And so forth. These are all abnormalities you need to find. Of course, in an exam, you might not have enough time to look for it. So you might have a question that comes to you as a case of MI. If there's a case of MI, always look for the ST segment. Look for the ST segment if it's there. If you can't find it, look for the other ischemic changes in MI. Look for a deep Q wave, inverted T wave, prolonged PR interval, and you'll see there are ischemic changes that might be present on an MI. Again, remember, for ST segment, if you see ST segment one lid, please make sure it is found in another lid. You have to have it in 2 lids or more. And according to the lids that is being seen with ST segment, you will know if it's MI and which type of MI. If you have an ST segment elevation, lid 2 and lid 3 in AVF, this is inferior MI. If you have ST segment elevation from V1, let's say all the way to V6, this is anterolateral MI. All right? Some questions might tell you which coronary artery is affected. In the case of anterior lateral MI, the left anterior descending artery, the artery that is supplying the left side of the heart anteriorly. So in the case of inferior MI, the right coronary artery and its branches, they're the ones that are occluded or affected in the case of MI. That's why you'll see ST segment elevation or depressed ST segment on lid 2, lid 3, and AVF. Okay? So, the summary, we know what an ECG is. We know the recording. We need to read an ECG in a systemic manner. All right? We need to look for the abnormalities horizontally and vertically. In case of MI, look for these 4 changes: deep Q wave, inverted T wave, ST segment, elevated depressed, prolonged PR interval, also axis deviation if you want, between lid 1 and AVR, all right, or AVF, sorry, okay? That's pretty much it for the ECG. I hope you enjoy.